Dermatology is a fascinating subject, and in this introductory lecture, we hope to outline the extent of skin diseases, the effect it has on both affected individuals and their families. Hopefully, will help in terms of describing skin lesions and points that need to be brought out in terms of taking a dermatological history. So what is dermatology? Well, dermatology is the medical discipline that is concerned with the diagnosis and treatment of diseases of the skin, the hair, also the mucous membranes and nails in both children and adults. But in fact, dermatology extends throughout the entirety of the individual's life. So antenatal diagnosis is important in some exceedingly rare but life-threatening blistering disorders, for example, such as severe epidermolysis bullosa. Obviously, the vast majority of patients seen in dermatology are alive, but we're occasionally called to make comments on rashes at post-mortem, particularly when there are issues related to non-accidental injuries. So all aspects of skin, nails, mucous membranes, hair and nails throughout life. Skin disorders are exceedingly common. Obviously, the skin is the largest organ in the body and it's visible, and it reflects both the health of the body and acts as a barrier against injury and bacteria. Skin disorders are the fourth most frequent cause of all human disease, affecting anywhere between 30 and 70% of people worldwide. And in many developed countries, it's estimated that around 20 to 30% of all primary care consultations involve dermatological issues. So, dermatological disease is a very common problem. So how do skin diseases affect individuals? Well, particularly inflammatory rashes such as eczema and psoriasis may be itchy, they may be sore, and occasionally dermatoses are painful, for example shingles. And obviously because they are visible, they produce disfigurement, they will produce self-consciousness and embarrassment, so people are embarrassed to expose their skin. And occasionally skin diseases smell, particularly things like hidradenitis, subpurativa, or other oozy flexural inflammatory conditions. Skin disease can result in people being anxious and depressed, and of course skin diseases may become complicated, particularly by infection. But any chronic ulcerating condition rarely can develop malignancy within them. And of course, treatment of skin disease can be time-consuming, costly, messy, and of course quite a lot of dermatology is the assessment of precancers and cancers of the skin, and of course their removal will give rise to surgical scars. Mercifully, really severe inflammatory skin disease is not common, but potentially life-threatening, producing metabolic, cardiovascular, thermoregulatory issues. So this is particularly so when more than 80% of the skin is affected by an inflammatory condition, which is called erythroderma. And also in very extensive blistering diseases such as severe erythema multiforme and toxic epidermal necrolysis. So how do we quantify the effect of a skin disease on an individual? Well, one of the commonly used generic tools, which is a questionnaire called the Dermatology Life Quality Index, or DLQI for short, is a self-reported questionnaire which involves asking about 10 items of life. The final score will range anywhere between 0 and 30, and if someone's got a DLQI in excess of 10, this indicates mild to moderate disease. A separate tool is used for children because different aspects of their life may be important. The Dermatology Life Quality Index questionnaire looks at 10 items. For example, over the last week, how itchy, sore, painful or stinging has your skin been? How embarrassed or self-conscious have you been because of your skin? Has it affected shopping or looking after your home or garden? Has it influenced the clothes you wear or affected any social or leisure activities? It also looks at questions such as if the skin has made it difficult for you to do sport, prevented you from working or studying. Has it affected or created problems with your partner, close friends or relatives, or caused any sexual difficulties? And finally, how much of a problem has the treatment for the skin been? for example, making the home messy or taking up lots of time. There are a number of tools which are used in dermatology which measure disease activity objectively. So rather than this being a quantification of the effect of skin disease on an individual, this is an objective score of the extent and severity of skin disease. And there are several of these tools which are used for a variety of different skin conditions. One of the most commonly used ones is for the assessment of atopic eczema, and it's called the EASY score, the Eczema Area and Severity Index, and this gives a quantification of the extent of the individual's eczema. It is useful in terms of trials and whether or not you're making a documented impact by treatment of skin disease. For example, if the EASY score is going from, let's say, 25 to 10 with the medications you've started. So the EASY score looks at the intensity of the redness, the thickness of the eczema, the intensity of the scratching, and whether there is thickening of the skin due to continuous scratching. And this will give you a finite number which you can record in the patient's notes. So it's very useful when patients are being referred, and it's also very useful as an objective measurement of therapy effect. We have a similar tool for measuring the severity of psoriasis. It's called the PASI score, Psoriasis Area and Severity Index, and again it's objective and it looks at a variety of parameters. So an assessment is made of the redness, induration, and scaling and desquamation, and again a score is assigned, and there are very helpful smartphone apps that can help in the computation of these scores. It's particularly valuable in secondary care dermatological practice. And there are a number of other tools that we use for other skin conditions, such as the APSIA score, which is a combination of both quality of life and extent of acne. There are tools to measure the severity of hidradenitis suppurativa, a chronic, nasty, inflammatory nodulocystic eruption which tends to occur in the axillary groins, and for other conditions such as pemphigus, an autoimmune blistering condition. And as I said, it's useful to determine severity of condition and the effect of treatment. So here we're just looking at the nomenclature. For example, the macule is a small patch of skin that is altered in colour but not elevated in comparison to the papule, which is elevated, and it can be solitary or multiple. The nodule is elevated and solid, usually located primarily in the dermis and subcutis. The plaque, a circumscribed palpable lesion, usually more than 1 centimetre in diameter. Most plaques are elevated. Now, the erosion is a sore due to the superficial or partial destruction of surface tissue such as the skin. The ulcer is a full thickness loss of the epidermis plus at least one portion or some portion of the dermis. Vesicle, small blister less than 5 millimeters in diameter, consisting of clear fluid, and the blister is similar to the vesicle but larger in diameter, usually more than 5 millimeters. So here are some pictures of what we have described previously. You can see in the first picture of the macule, it's pigmented. It can also be hypopigmented in conditions such as vitiligo. You can also see in the picture of the plaque, this is psoriasis. You can see that the plaques are usually palpable elevation of the skin, usually more than 2 centimeters, and rarely over 5 millimeters in height. And on the left hand side, third down, we've got an example of chondrodermatitis nodularis helices. So a wheal is a transitory compressible papule or plaque of dermal edema, red or white in colour and usually signifying urticaria. A pustule is a visible collection of free pus in a blister. It can indicate infection, but not always. A sinus has one open draining end, and the channel ends in a blind ending. And finally, a cyst is a nodule consisting of an epithelial-lined cavity filled with fluid or semi-solid material. Arriving at a diagnosis clearly depends on history, physical examination. The examination will concentrate on both morphology and distribution. So lesions may be distributed as a round coin-shaped lesion, which we can call discoid or nummular lesions. Lesions arranged in a line or linear fashion. For example, we can see this in shingles. We can see target lesions in erythema multiforme, and it looks like a bullseye, a triphasic ring-like lesion. We can see gyrate eruptions. Lesions may develop like a ring, so we call these annular lesions. And it's important to determine if there is symmetry or asymmetry. So diagnosis depends not only on morphology but also distribution. So let's have a go at describing the lesions here. Are they nodules, papules, pustules, plaques? Well, I think you can see a combination of largely papules, but I think one of the central lesions may be developing into a pustule. They are grouped and arranged around the eye. You can't see it in this image, but it was symmetrical, affecting the other side in almost an identical distribution. So this is periocular dermatitis, and its morphology and distribution is absolutely characteristic. This lesion here is one of many, but it's actually on a relatively elderly lady's abdomen. So how are we going to describe this? What we can see here is an erythematous area, but situated around the periphery, there are a combination of vesicles and blisters. You can clearly see the roof with fluid inside a number of these lesions. The vesicles are relatively small, perhaps 3 to 4 millimeters, but the blisters are just over 1 centimeter in diameter. The lesions are arranged around the periphery almost like a string of pearls. Some of the blisters are filled with blood, but some, especially at 9 o'clock, are clear. So this is an immunobullous condition. This distribution and morphology is typical of linear IgA disease. So this person has developed this eruption on their palms. So how are we going to describe these? Here we can see a combination of both vesicles and blisters, and if you look really carefully, some of the larger blisters, particularly in the center of the palm, you can see there are multilocular. It's as though the larger blister is made up of lots of little vesicles within it, and it's symmetrical. So this appearance is fairly typical of an acute eczematous condition, which is called Pomfrey's eczema. So the morphology is vesicles, which are coalescing into producing blisters, so on the palms and the soles, and very little anywhere else. And the symmetry is highly suggestive of Pomfrey's. So how are we going to describe this? This man has had a lump which has been growing quite quickly over the last 6 weeks on his forehead. You can see it's a solitary lesion and it's a nodule. It looks about 2 to 3 centimeters in diameter. It's red, and you can see some little broken blood vessels, which we call telangiectasia. We can also see centrally it's beginning to ulcerate and necrose. So this is a rare tumour, a Merkel cell tumour, which is a rapidly enlarging erythematous nodule, which is showing areas of central ulceration developing. So how are we going to describe this? This is the medial malleolar area of an elderly lady who is quite disabled and spends a lot of her time sitting in a chair. Well, this is an ulcer. The lesion you can see here, what about 4 by 3 centimeters in diameter, is ulcerated. So not only is the epidermis being lost here, there is also loss of some dermal tissue. It's got central slough. The edge of the ulcer is fairly regular, and it's not particularly overhanging or purple. You can see the surrounding skin is also abnormal. You can see it's pigmented, slightly scaly, and the lower leg is edematous. These are all features of venous or gravitational ulcer. The ulcer is arising on abnormal skin, and the patient's got clinical evidence of venous hypertension and reflux. This is a typical venous or gravitational ulcer. So how are we going to describe this? The owner of this arm has kindly drawn on her arm, and about 10 minutes later it's become itchy and raised. We describe this as a wheal. Whealing is something which gives the appreciation of something which is rather like a nettle sting. So there is swelling of the skin and it's been induced by a stroking pressure. So this is whealing, and it's inducible urticarial condition called dermographism. So an example of whealing. So how are we going to describe this problem? This patient was perfectly well about an hour ago, and over the course of the last hour she developed swelling of the tongue. This is something called angioedema, so swelling of the soft tissues. It tends to affect the lids, tongue, lips, and sometimes the genitalia, and it's temporary swelling which comes up quite acutely and generally resolves within 24 to 48 hours. There are lots of causes ranging from drug reactions to stings and bites, to rare enzyme deficiencies such as C1 esterase inhibitor deficiency. So this is angioedema, acute swelling of the tongue, which could potentially be a medical emergency, as if it extends to the pharynx it may restrict inhalation and produce asphyxiation and even death. So how would we describe the distribution of this eruption, and what does this suggest? This lady has got a very well defined red eruption which is affecting both the face and the V area of the chest, and it seems to be spared underneath where her clothing covers her skin. This makes us think of two things. Is this a photosensitive disorder? Is the light affecting the skin producing this inflammatory condition? The other thing we should think of is, could it be due to exposure of an airborne volatile product which she is allergic to? Usually, if it's photosensitivity, the back of the hands are affected and there is sparing between the fingers. There is also sparing under the chin, as we can see here, and behind the ears. In airborne contact allergy, the upper lids are often affected and between the fingers are also affected. So the distribution suggests one of the two. Here's another example of where the distribution of eruption helps determine the cause. This man has had a rash on his face for a number of years, but it's always worse in the summer months, and you can see the sparing underneath where his collar starts, and he has protection of his skin by wearing clothing and also from wearing a cap. He's got a absolutely distinctive sparing underneath his cap, and where the edge of the cap stops, the eruption is affected. This was actually a drug-induced photosensitive reaction, and of course the distribution gave us a clue to which of his many drugs may be causing the problem. So how are we going to describe the distribution of these lesions? This is the back of the hand of a teenager who had these lesions for a number of months. The most important thing here is you can see they are composed of red rings, and if you look carefully you can see the edge of these rings are slightly raised. And if you almost stretch the skin, you can even feel these almost slight nodularity of the margin of these rings. So this is an annular eruption, and in this distribution and age, the most common condition to cause this is granuloma annulare. But again, the distribution and morphology and the absence of scale is helpful. If it was scaly, you'd have to think of a fungal infection. So this is a man in his late 40s, and he's got these eruptions, but it's only affecting the hand and arm on one side. So it's an asymmetrical unilateral eruption. He tells us that he developed a sore area on his middle finger and then developed these nodules which are extending up his arm. And in fact, these are extending along the lines of the subdermal lymphatics. So what you can see is these nodules, which in areas look as though they're breaking down to produce abscesses, but arranged in this linear and ascending distribution. So this is fairly characteristic for atypical acid-fast infections. So these are TB-like organisms, usually acquired from swimming pools or tropical fish, which are infected with this TB-like organism called Mycobacterium marinum. This distribution is called sporotrichoid because the other condition which produces this, which is very rare in the UK but quite common in the tropics, is sporotrichosis and produces this linear ascending distribution. So here's a patient who has a symmetrical eruption. So the eruption is identical on both palms. This is a youngish patient who developed a temperature and a cough about 10 days ago and then developed these lesions symmetrically on both palms. So these are the iris or target lesions, which we see in erythema multiforme. So you can see these concentric rings producing the lesions of erythema multiforme. This patient was well until about 5 days ago when he developed a painful eruption which spread around the right side of his chest. How are we going to describe the morphology and distribution? So the morphology, what we can see there is clustered what are now pustules. So if we'd seen him a couple of days ago, we would have seen clustered vesicles, but these vesicles are now filled with pus. And the distribution is now extending linearly around the chest. It extends onto the back, but stops abruptly at the midline. So this is a linear dermatomal vesicopustular eruption, and in this setting it's shingles, reactivation of the varicella zoster virus. This is a typical appearance and a fairly common sight. Here's a man in his early 50s who's developed this eruption on the back of his left thigh. It's been present for about 6 months and the lesions are intermittently quite tender. So how are we going to describe this? Well, you can see this rather livid net-like eruption, which we call a reticulate eruption. And if you palpate this, you will be able to feel tiny little nodules. So this is a reticulate eruption due to an underlying medium-sized vessel vasculitis called cutaneous polyarteritis nodosa. But the distribution is the clue to the diagnosis. The distribution and morphology is typical. So here's a man with an eruption in his groin. So we need to think about how we're going to describe this. Well, what we can see is a very well marginated patches and almost plaques on his inner thigh. They are arranged in this annular fashion and also in areas in arcuate fashion. But the important thing is the edge of these lesions are scaly. So in this distribution with scaling, with very well marginated lesions, one's first thought should be, is this a fungal infection, tinea cruris? And in this one, it's almost circles within circles, so we call this circinate. This is a typical appearance of a fungal infection. So different lesions and rashes will have different colours. For example, in carotenoderma, you have this yellow-orange skin due to excessive circulating beta-carotene. In hyperpigmentation, you often have darkening of the skin compared to normal. It can be localized or generalized. In hypopigmentation, the skin color is paler than normal, whereas in leukoderma, you have white skin, also known as acromia. Now, in an infarct, you often have black areas of necrotic tissue. This is due to interrupted blood supply. When you have jaundice, you have yellowing of the skin and the whites of the eyes due to buildup of bile pigments in the blood. This is usually due to biliary or liver disease. In erythema, this is red skin due to increased blood supply. And in erythroderma, this is a skin condition affecting the whole body or nearly the whole of the body, which is red all over. One or two other examples of characteristically coloured eruptions. So how would you describe the changes occurring around this man's mouth? Well, what you can see there is almost a slate grey blue discoloration of the skin around the mouth and lips. This colour is highly suggestive of a deposit of coloured drug under the skin. Drugs that tend to do this are the antiarrhythmic amiodarone, the tetracycline antibiotic, aminocycline, and we also see it with anti-malarial tablets, particularly hydroxychloroquine and mepacrin, which we use a lot in dermatology as anti-inflammatory agents. The colour is highly suggestive of a drug deposition. Here's another example where the colour may give you the clue to the diagnosis. This lady's got chronic weepy lower leg ulcers, but what has happened to the dressings? What colour are they? You can see that there's a green tinge, and that usually means there has been colonisation of the ulcers with Pseudomonas, which produces the pyosine and green pigment which is staining the dressings. Here's a lady who is complaining of discoloration of both of her buttocks, and the history gave the clue here, as she had been previously treated with intramuscular iron for a recalcitrant iron deficiency anemia, and unfortunately some of the iron has gone under the skin, so the grey-black colour here is due to iron. So here are some colours of lesions and rashes. We have telangiectasia, which is the prominent cutaneous blood vessels, which are usually red or purple, and then purpura, which is bleeding into the skin. It can be small red, purple or brown spots, as you can see in this picture. So making a diagnosis, particularly of rashes, the mainstay of treatment is of course taking a history, examining if possible the whole of the skin, which includes the palms, soles, and if appropriate, examining the genital area, the nails, scalp, and mucous membranes. And of course then we might supplement history and examination with special investigations, most commonly things like mycology, bacteriology, blood tests, biopsies, and perhaps more specialised tests such as immunofluorescence for immune blistering conditions and genetic testing for genodermatoses. In taking a history, the following points are obviously really important. When did the rash start? How long has it been there for? Where did it start? Where has it moved to? Has it been symmetrical or asymmetrical? Has there been any other associated symptoms either before the rash started or during the evolution of the eruption? So was there a prodromal illness such as a sore throat, fever? Has there been an itch or pain? Have there been any other systemic symptoms such as abdominal pain, sore joints, etc.? What makes it worse and what makes it better? So is it made worse by heat? Does sunshine exacerbate the eruption? What about physical pressures such as stroking the skin? Does cold make it better or worse? Has any of the treatment made it better or worse? It's also useful to ask how long do the lesions last. So if the eruption is ongoing but individual lesions are coming and going, if they're coming and going really quickly within 24 hours, and particularly if they've got wheeling morphology, well, that's highly suggestive of an urticarial condition. If lesions are much longer lasting, that's going to make you think of a different differential diagnosis. And of course, it's useful to ask open questions. Is there anything you think that has caused this? Because sometimes only by asking this you'd get a clue, as only the patient will know what they've been doing. Just going further into treatment, obviously we need to know what have you used, how much and has it helped or hindered. It's useful to have prescriptions that have been dispensed, and often patients will bring these with them. So if someone is covered with eczema but has used 10 grams out of a 100-gram tube, it's not very surprising if the treatment hasn't worked. So we need to ask about how much they've used and what they've been using. Occupation can be important, so if someone is allergic to something they're exposed to at work or at home, does it get better when they go away on holidays? Does it get worse when they return to work? It's important to ask about activities and hobbies and if they've travelled. We should ask about past medical history, both general conditions and those related to skin conditions. It's also important to ask about family history and drugs. Have they been exposed to any medications? What about the timing of exhibiting the drug relative to the onset of the rash? If they started a drug 1 month before the rash developed, this may be very relevant. It's important not only to ask about prescribed drugs, but also over-the-counter drugs and illicit drugs. We should ask whether they smoke or take alcohol. Socioeconomic aspects are also important and useful to know about. If there is anyone at home that can help them with topical treatments, have they got transport in case you want to suggest hospital-based ultraviolet light therapy or day case treatment? Also, how does the condition affect you? And of course, this can be helped by DLQI and other metric tools. We should also ask if anyone else has been similarly affected. For example, if someone has suddenly started to itch 6 weeks ago and 3 other people in the household are also affected, this could be highly suggestive of scabies. It's also important to ask which symptoms bothers them the most, so we can tailor and address our treatment to control the symptoms to the best of our ability. So here we've gone over the issues in the history, important issues in terms of describing morphology and distribution of rashes, and of course issues related to the relative common occurrence of skin disease and how it may affect people.